Welcome to Module 5B. Today we're going to be talking about respiratory disorders and ventilatory assistance, better known as vents. So the objectives that we're going to talk to today, so in this lesson, we're going to be a little brief overview of the anatomy and physiology of the pulmonary system, because that's important for you guys to remember, because we're going to be talking about some more advanced concepts and you need to be able to relate it back to these things, okay? Just some common respiratory disorders. You should have already learned a lot of respiratory disorders in your med-surg classes, so we're just going to be building on those with a few more situations. And we're going to also be going over ventilation, vent settings, those kind of things. Also, another review of ABGs. Again, you guys should already know ABGs, so it's just a very brief overview and the interpretation of those, as well as just some diagnostic studies and basically the holistic nursing practices, but malignant hyperthermia. Okay, so a brief little anatomy and physiology review, okay? So the basics of the pulmonary system is, like I said, it's important for understanding what we're going to be talking about today. Okay, so the primary function of the lungs is to facilitate gas exchange. So that's taking in oxygen and expelling carbon dioxide. Okay, the process occurs in the alveoli, those tiny little air sacs in the lungs where the oxygen diffuses into the blood and the carbon dioxide diffuses out. You need to think of the alveoli as the body's gas exchange units. They're surrounded by capillaries that carry the blood to and from the heart. So the respiratory system includes the bronchi, bronchioles, which act as the airway delivering air to the alveoli. So breathing is facilitated by the diaphragm. That's that dome-shaped muscle beneath the lungs that moves up and down with each inhalation and exhalation. And also the intercostal muscles, which are the muscles between the ribs. When the diaphragm contracts, it flattens, which creates a negative pressure that draws the air into the lungs, which is you inspiring air. So inspiration, taking in air. When it relaxes, air is pushed out, which is expiration. The mechanics of breathing are vital because any disruption in it can lead to the complications like a pneumothorax or respiratory failure. So keep these structures and their roles in mind as we talk more about the disorders that are affecting the pulmonary system. The only other thing I want to add to this is, remember, when I say ventilation, that is the aspect of physically moving air in and out of the lungs, okay? Breathing and ventilation. Breathing, when people use the term breathing, that is, it's not a technical term, but they generally mean that's air moving in and out, but it's also the gas exchange part. Ventilation is purely just the movement of air. That can be a problem and lead to respiratory issues, but also you might be able to move air in and out. That might not be the problem. The problem might be in the alveoli and through the tissues is actually that oxygen and carbon dioxide exchange being able to go back and forth. So that could be the cause of why you're having respiratory issues as well as the ventilation. I hope that makes sense. There's two different ways that we could be having issues with oxygenation. Okay, so let's talk about pneumothoraxes. Okay, this is we're going to talk again about this in the trauma section, but we're going to start here. So, what is a pneumothorax? I have a picture on this screen, and it shows lungs. Okay, so the one on the right side is the lung inflated, and you see like the little pleural space around the lung and the pleural lining, and it's able to inflate and deflate. Where on the left side, the lung is shriveled, okay? Because in the pleural space, there's all this air that's trapped. Now, it can come from, pneumothorax can be caused by different things, okay? The most common one is trauma, but we'll get into those here in a minute. But so just in general, what a pneumothorax is the air is in that pleural space, the area that's between the lung and the chest wall, and it causes that area of the lung, it can't expand, and so it collapses or partially or completely collapses, okay? The symptoms involved with a pneumothorax is like chest pain, and it's typically sudden, shortness of breath or having difficulty breathing, rapid heart rate, and hypoxia. Now, we're going to talk, there's some more symptoms involved depending on what type of pneumothorax it is, but those are just general symptoms, okay? So like I said before, the number one cause is trauma, like a rib fracture. A rib breaks and it pokes into the lung. So that a penetrating injury, like a gunshot wound, a stabbing, but it can also be from a blunt force trauma, like a steering wheel, like crushing into you. Um, Spontaneous rupture of the blebs in the, like around in the alveoli and the part of the lungs, it can happen. So it can happen spontaneously. It can also happen when somebody's on a ventilator and we have the pressure pushing too much into the lungs. It can actually cause little tears where in the lungs, like you're pushing so much air in and the force goes, it's too much of a volume amount or the force, and then it pops open and then the air kind of escapes. So the air can come from the outside or it can come from the inside. But basically that air is getting trapped in that space around the lung on one side, okay? So now, spontaneous. This happens when there's not an obvious cause or an injury. Like all of a sudden they have a we call it pneumos for short. Like they have a pneumo and they didn't just fall, nothing hit them. This happens more commonly like in younger males, but it can happen to anybody, okay? It says often tall, thin, young males. Very true. They're often typically athletic too. It's kind of weird. But like it can come from lung conditions like COPD, cystic fibrosis, or lung infections. So if it's a small one, a lot of times we just monitor them and don't do anything, but the larger ones might require a chest tube or needle aspiration. Needle aspiration is more for emergent, so it's more a chest tube. And it wouldn't be an emergent chest tube. It would be like we would have time to go in. We can do it at the bedside or we can take them to the OR and do it, but we'd be nice and give them some medication to calm them down, maybe even sedate them while we insert this chest tube into their side, as opposed to a traumatic and emergent one where we're just slicing you open on the side. No time to wait. Okay, so a traumatic pneumothorax. So this is one that results from an injury to the chest. So blunt or penetrating trauma. So rib fractures, stab, gunshot wounds, blunt force trauma. A lot of times steering wheels are like the cause of these. But it can happen from anything. It could happen from a fall. You land on something that crushes your chest and then it break, like your ribs can break into, or like your sternum can like kind of cause a little tear onto your lungs. Okay. So this is the direct injury that allows air to enter into the pleural space from the outside of the lung. So these are typically emergent, and we can do what's called a needle aspiration. And you're not going to learn this in practice, but if you actually take ACLS, they teach you this. Paramedics and people like in the military get trained for this. But you actually can take just like an angiocath, like a needle for an 18 gauge needle. You go like second intercostal space, mid-clavicular line. You just stab it right there and you'll hear air escape. People that have worked on like farms with cows and stuff, cows can get like spontaneous pneumothoraxes, and like literally like the rancher farmer people, they'll actually take a needle and stab it into the side of the cow. And then there's this huge air, like hissing, escaping. And there's always like one or two people that have been around this and they've heard it before. Like it's kind of interesting, but anyways, that's what needle aspiration is. It's just to let the air out really, really quick that's trapped in that pleural space so that lung can expand again, but it's going to come back because there's still a hole. So we still need to take care of them and cover things up. But in the meantime, it buys us time. Chest tube does the same thing. We insert chest tube into the side. It goes into that pleural space to let the air come out without letting it get back in. We'll go more over chest tubes in a second. But like we're slicing you open on the side and it's kind of painful, but if it's emergent, we need to do it. So, and again, surgical intervention, we can take you to the OR if we have time, but not when there's a tension pneumothorax. So a tension pneumothorax is it can be caused by a spontaneous pneumothorax, but it's most often caused by a traumatic pneumo. So it's caused because that air is coming in, and what has happened is it's compressed that side of the lung so much that lung can't expand at all. Okay. This is life-threatening. This is emergent. This patient has seconds, maybe minutes, not very much long to live. Okay. If we do not immediately let that air out so that lung can expand, their heart is going to stop very, very quickly. Okay. This is something that is definitely, it will get your heart rate going if you are an ER nurse. We see these a lot in the ER in a trauma center. You will also see these sometimes after a cardiothoracic surgery, potential. I mean, you don't have to see it all the time, but you can see it, like if you're post-op ICU kind of thing and somebody's had surgical interventions on their chest, and we may have caused an accidental something to the lungs, and they can get a pneumothorax that can turn into a tension pneumothorax. Okay. So the symptoms for this: severe respiratory distress, sudden chest pain, dyspnea. They're going to have difficulty breathing, obviously. But here's where it gets intense. Tracheal deviation away from the affected side. So that trachea is going to turn and kind of slant sideways towards the good side of the lung, not the side that's injured and that the lung is collapsed on. It's going to go towards the other one because of the pressure is still able to breathe in and out. It's going to do that. If you see tracheal deviation, you need to be like emergently like preparing for a chest tube. Like, we're not taking them to the OR. We don't have time. It's going to be at bedside. Okay. So just remember, tension pneumothorax is a critical condition. That air is getting trapped. Okay. It causes that progressive buildup of pressure inside that the collapsed lung on the affected side actually pushes on the heart and major vessels towards the opposite side. So what that does is the shift can severely impede the respiratory and cardiac function, leading to a decreased venous return to the heart, okay, which then reduces the cardiac output, which is why that hypotension is a sign of this as well, okay? This is, again, what I'm going to tell you is that there's often when you hear somebody getting shot or stabbed on the news and you hear the story goes something like this: they were shot or stabbed and they ran a few feet or were able to run out of the house into the neighbor's yard where they collapsed. I would put money on it that this is what got them, okay? That they got a tension pneumo. They were able to run and live for a few minutes before their heart stopped, okay? I will tell you that because every breath, what it happens is first there's like a little tear, right? And so every breath, a little bit of air comes in there, okay? And then every subsequent breath, more and more air gets trapped, and the ability of that side of the lung can't expand more. And it happens pretty rapidly, okay? Like, it can just take like 30 seconds, but it could be like 5 minutes. There was a police sergeant, Sergeant Brewster. This was, I don't know, it's in the past 10 years. He pulled over a vehicle. I think he was like looking for a suspect of a robbery or something that just happened. And there was a car that met the description. He pulls it over, and immediately upon exiting his car, the guy in the car that he pulled over immediately just starts open firing on him and shooting him. He gets shot multiple times. This is a real story, just FYI. He got shot multiple times in the chest, and he immediately on his radio, that's, attached to his chest, he radios in. He's like, "Shots been fired, blah, blah, blah." And he he was a little out of breath because, maybe most people are if you just got shot at, your adrenaline's running. And he's like, "I'm pursuing the guy." And he pursued the guy on foot, and he made it like 2 blocks, and then he collapsed. This is what happened. This is what he got a tension pneumo. Now, if he had stayed still and tried to just very calmly breathe and not chase after the suspect, which would decrease more air. Every time, think about like when you're running gasp of air in, the gasp of air, he's sucking in a lot of air that's now compressing from it's causing these issues. Okay. So would he have survived? Who's to say? Okay. If he had saw that he was so if one of the things you can do, and we're going to go over this later in a lab, it's part of the Stop the Bleed campaign. But one of the things is if you have a penetrating chest wound, like a stabbing or a shot or something where it's penetrating through the chest, you need to seal it from the outside. So what's the best thing? Like a Tegaderm, like plastic, right? And they actually have chest seals. So it's just basically like a Tegaderm that you slap on the outside. But anything would work. Go get Saran wrap. I don't care. Any cloth that is wet will create a seal. So even if all you have near you is a sock and there's a pool of dirty, muddy water next to you, guess what you do? You rip your sock off, you dip it in the muddy water, and you slap it on that hole. We can take care of an infection later. We cannot get your heart starting back up if this is what causes it to stop. Okay? So like these are some of those things that like you learn as an ER nurse or like a paramedic, or like you're combat trained in the military. But a lot of police officers these days, they actually carry chest seals on their person. They also carry tourniquets. Like you would never know it. It's like shoved in their pockets, but they know that this could buy them time. It's not going to buy them a lot of time, but it could buy them time until an EMS unit gets there. EMS can do needle decompression. They can do some things to maybe keep you alive until you get to the hospital so you can get a chest tube in. Does that make sense? I hope that makes sense to everybody. But this is life-threatening. It's a big deal. We're going to talk more about it in lab when you have a lab. I think that's in like about a month's time. But yeah, so big thing about attention pneumothorax, you have minutes. It's life-threatening. If there's tracheal deviation, you only have minutes or seconds before that heart stops. We need to decompress the air with a chest tube or needle decompression. So a hemothorax. So this is not air in that space, it's blood. Sometimes it's a mixture of blood and air. Same thing. Okay, we kind of treat it the same. But needle decompression is only going to relieve air. It's not going to relieve the blood. So we need a chest tube in these people. Okay. A lot of times it happens because of trauma. Okay. And so every time the lung, every inhalation, exhalation, when the lung, shrinks before it expands again, the blood will pool in here. So then every subsequent breath they take, there's less room for that lung to expand. Just like with the pneumothorax, it's air trapped. A hemothorax is blood trapped. Okay. That's the big difference between the two. So what is the management of a pneumothorax? So nursing care for a patient with a pneumothorax involves frequent and detailed respiratory assessments. We're talking frequent. They're not going to go to a med-surg unit where you see them every 4 hours. They need to be in the ICU, okay? Maybe if it's small and maybe if it's non-traumatic, they can go to an IMU, but they're going to go to a more monitored floor, okay? The nurse is going to need to monitor their respiratory rate, the rhythm, breath sounds, oxygen sats closely, okay? Those parameters can change rapidly if the pneumo gets bigger and worsens, okay? So you also want to position the patient in a semi-Fowler's or high Fowler's position because that can help the ease of breathing and promote lung expansion as long as it's not contraindicated for any other reason, okay? You also will be administering supplemental oxygen because they have decreased breathing room and the capacity for their lung to fully expand, which would then create more surface room in those alveoli for the gas exchange. So since it can't expand fully, we need to be making sure that what is in there is like more beefed up oxygen rich air so that they can have, their oxygen sats stay up. I guess that's the easiest way to say it. So it's super important that we're going to educate our patients on the importance of that deep breathing and incentive spirometry because we want to be expanding and opening the lungs up as much as we can. So again, it's going to help with that re-expansion and prevent atelectasis of the lungs. Okay, be sure you're vigilant on watching the chest tube function if one is in place and ensure the drainage system is set up correctly and it's functioning as intended. You're also going to monitor for signs of infection on the side. Anytime we have a cut to the skin, there's always a risk for infection. So that's always important. We do not want to get it infected, obviously. So remember, signs of infection are things like fever, increased drainage, increased redness, those kind of things, okay? We're also going to make sure that the chest tube, if it's in place, it's going to remain securely in place because it can get dislodged, which means it could move outside of the lung. That's not good. And so normally they use a suture and they actually suture it to the side of the chest. So you're going to look at the documentation and there's some markings on the chest tube and you're going to see like what centimeter it's at the chest wall, and you want to make sure that every time you're looking at it and checking the site, you're making sure that it's at that same number, because if it's not, then it's moved and we need to be notifying people, getting a chest x-ray and seeing what's going on with the patient. So a little bit more about chest tubes. So the picture on the screen right here is a picture of a chest tube. And you can see like the little black wires around it. It's like tied around the tube, and that inside the gauze, if you were to see it without the gauze on there and without the dressing attached, you would see that that's the sutures that are attached to the chest wall. So you can see that there's some blood. Even with a pneumo, there's going to be blood. I mean, there's going to be some blood in there, okay? Even if it's not a hemothorax, because we're slicing open the chest, so there's going to be some bloody drainage. That's normal, okay? It's expected. But So you want to, chest tubes, like again, are used to remove air, blood, fluid, and even pus from that pleural space, okay? And it helps to re-expand the lungs and restore that normal breathing. That empyema, look up what that is. Pus, just you need to know what that is. Okay. Anyways, okay. So insert positioning. Typically, it's the 4th or 5th intercostal space mid axillary line. So like in the armpit region area. The placement is confirmed with imaging, so we'll probably do a bedside x-ray unless they had this placed in the OR, just to make sure it's in the right place, okay? And then we're going to hang it up. So the nurse is not going to be the one placing this. It's going to be a physician or advanced practice provider. It's our job to help set up the drainage system as they're placing the tube in the chest system. We're going to go over more on the drainage system in just a second. But This is done under sterile procedure, and then we connect it. And once it's connected to the chest tube system, then it's a closed system. Okay, so the components of the chest tube system include the drainage chamber, water seal chamber, and I know this means nothing to you right now. Hold on a second, and the suction control chamber. So right here. So that picture now on this screen, this is an atrium. This is the most commonly used chest tube system that you're going to see out there. There may be a little different variations in like the coloring of this, but this is the more popular brand that a lot of places use. So if you see right there, it looks all crazy and whatnot, but that tube that's corrugated at the top that comes in on the top right side, that part right there eventually gets connected to the patient. And then so you see that first on the very right side where there's blood, and it goes from 0 up to 200, and then it would spill over into the second column. And if that fills up, it would spill over into the third column. So that's the drainage right there. Okay. But those three columns are all connected. And they're also connected to where you see B. You see where that says B? And then if you follow that and you go all the way down to the bottom left hand, you kind of see a blue coloring area. That's water. That's the water seal. So if you think about it, that tube comes out of the chest all the way and it goes through this system, and then water. So if there's air, you will see some bubbling in there. Okay. If it's continuous bubbling, there's an air leak somewhere and they're getting too much air in. But there will be, and there's also a little ball right at the very top of that blue section area there, and you'll see that go up and down. That's called titling. So every time they take a breath in and out, there's going to be fluctuations in that, and that's completely normal. So again, as a nurse, you're going to be looking for signs and symptoms of infection at the site. You're going to be looking for subcutaneous emphysema, crepitus. That's the feeling of the little crackles under the skin. Go back to health assessment. Because sometimes if the tube is displaced or inside the body, some air could be escaping into the tissues around the chest wall. And so you might feel crepitus. So you should be assessing for it. If crepitus is there, that's not good. No crepitus is good. Crepitus, bad. You're going to also, I already talked about, the securement of the tube, and also you're going to be looking at the drainage output. I will tell you, this is why most nurses carry a little baby Sharpie marker on their badge, because at the end of every shift, you're going to draw a line wherever that drainage is at, and you're going to mark the date and the time so you can very quickly and visually see, yes, you're going to be putting that documentation in the system, but we're not going to empty this drainage out every shift. So you need to be able to see how much got added on your shift. So you need to draw a little Sharpie marker line on the little thing. And this is one of the many reasons why we have Sharpie markers. But you'll mark a little line. So you want to also be noting the drainage output, the color, the consistency, if it's fluid or not, whatever the case may be. Okay. Then the maintenance, again, it should always be below the patient's chest to prevent backflow. So it's at or below the level of the patient's chest. You would never set this drainage system, if you were taking the patient to CT, out of the unit, you're not going to put this on top of them where it's above their chest, because it's not going to drain. We're letting gravity let it drain into the system. So it needs to be at or below their chest. You also hook it up to suction. And when you're not hooked up to suction, some of the things that you can do is you can put it in water, a glass of water. It would be sterile water. That's one of the things that could be an option. And that keeps the system in a closed system, because you will need to keep it into a closed system at the end of the tube. So monitoring your patient, again, respiratory status, you want to make sure they have breath sounds on both sides and they're in all lung fields. Kind of important, right? Their respiratory rate, their O2 sats, also the signs and symptoms of complications, if they have increasing dyspnea, if increasing pain, it should be staying the same or getting better, not getting worse. Obviously, evidence of a blockage or dislodgement in the tube. That could be crepitus. That could be no drainage in a whole shift. Well, why is there no drainage happening? That's weird. We should be having drainage, that kind of thing. So be monitoring and looking out for those. So some other issues, air leaks. So air leaks is a persistent bubbling in the water seal chamber. So on this picture, it's that purple box. That's the water seal chamber right there. Okay. That indicates an air leak. You need to assess the connections and the patient if you see that. Okay. So no drainage. So check for kinks or occlusions in the tubing. Sometimes there's a big blood clot in the tubing and you need to get the blood clot out and into the drainage system so that blood and everything can drain, or water or air, whatever, can drain into the tubing system. Dislodgement. Okay. If the chest tube dislodges, cover the site with sterile gauze and notify the provider immediately. Just kind of like how I was talking to you about, like if the chest tube's not in the system, or let's just say it gets pulled all the way outside of the chest wall and it's like not even attached to the patient anymore. We want to cover that site up, right? Because it's just like what I was telling you a minute ago, like in an emergent situation out in the field, like you would just cover it up with like a Tegaderm or chest seal with a dirty sock with water kind of thing. You would need to cover it up. Obviously not in the hospital system. You want to sterile gauze if you're in the hospital, but and notify the provider immediately. This is like a stat, like we either need to replace it or take them to the OR pretty quickly. And you're going to be monitoring the patient for signs of respiratory distress because they could get another tension pneumothorax too with that if it gets dislodged. Okay, switching gears now. Pulmonary embolisms. Okay, these occur when a blood clot, typically originating in a deep vein in like the leg, like a DVT, travels to the lung and obstructs one or more of the pulmonary arteries. This is kind of like a heart attack of the lungs. This is like a lung attack, okay? The blockage can impair the gas exchange, which causes a reduction in the oxygenated blood flow to the rest of the body. So this can cause death to part of the lung tissue. And then if there's death to that tissue, then it can't do oxygen gas exchange, right? Okay. So risk factors for PE include conditions that increase blood clotting, such as prolonged immobility, recent surgery, malignancy, or like a clotting disorder. I will tell you, and I do not quote me on this stat, but it's somewhere around this, that they have done the data collection and sudden cardiac arrests. That's when they've done autopsies on sudden cardiac arrests. Like, so we don't know why all of a sudden their heart stopped, right? And they weren't able to make it and they were pronounced dead, right? They've done autopsies and over 70% of them, they're not heart attacks, they're PEs. Okay. So this is actually a bigger deal than most people realize. And it happens a lot more often. And the big thing I want to say on this is, like, if you ever hear of somebody, especially older person, but it can happen to a younger person too. Like, they just recently went on a trip to somewhere and they rode in the car for a long time. They flew on an airplane for a long time. They are at high risk of a PE. So I will tell you that. Here's a good example. One time I was taking care of a patient. I was doing triage in an ER. And this, I remember this is like kind of like a grandma. And she was there with like her daughter and her husband. And she checked in with knee pain. Okay. So she was knee pain. And like, that's not a high priority. So I basically, like, I'm checking in, like, I'm triaging in the chest pains first. And then I call her up there and I see her stand up and she's kind of clutching her chest and they're kind of helping her walk. And I go over to her and I'm like, hey, do you need a wheelchair? Like, is your knee that bad? And she like can't breathe very well. And I go, wait, are you checking in for knee pain or breathing issues? And they were like, no, it's knee pain. But like, I've been having difficulty breathing today. And I was like, let me get a wheelchair. Go get a wheelchair. I said, so where does your knee hurt? Well, she doesn't point to her knee. She points to the upper part of her calf. And then I noticed, I look at her right and her left calf, and one is significantly larger than the other. And I looked at her and I said, any recent travel? They go, how did you know? Yesterday we drove back from Oklahoma. And I started laughing inwardly, not outwardly. And I said, okay, come with me now. And I didn't even stop in triage. I just took her to an open room because I was pretty sure she had a PE from a DVT. Like, she didn't even need to do anything else. Was it that? Yes. But like, you can easily tell, like, I was like, she's having difficulty breathing and looks like she has a DVT. She just recently sat in her car for hours and hours and hours on end yesterday. And now it's dislodged and went to her lungs. Yay. Yay for the patient. No, not yay. Okay. Anyways, so that's an example of how you can use your brain to figure out what's going on with your patient without even having any x-rays or lab work back. Pretty cool, right? Okay. So those patients with PEs, just remember this, that they often present with a sudden onset of dyspnea, sharp chest pain that may worsen with deep breaths, tachycardia, and sometimes hemoptysis. Okay. So that's, bloody sputum. Diagnosis is confirmed using a D-dimer test. What is a D-dimer? If you don't know what a D-dimer is, go and look it up and refresh your memory. You guys should know what a D-dimer is, but if you don't, go look at it. Here's a hint. It's basically if you have clots in your system, it's going to be elevated because it's showing a presence of clots in your system. Okay, anyways. So Okay, a little bit more about D-dimer because I have to. Okay, so D-dimer, it detects the fibrin degradation products in the blood. So if you have clots in your body immediately sees a clot and thinks, "Hey, you don't belong here. I need to break you down." So your body starts releasing these things called fibrin degradation products. They go and bust up clots. So if you don't have clots, your body doesn't release the things that are going to break up clots. A D-dimer is testing if those things that break up clots are present. I hope that makes sense. So it's not detecting the clot, it's detecting the things that break up the clot. Okay. So if you just had a big, huge major surgery, do you think your D-dimer is going to be elevated? Yes, because you're going to have clots, right? So it's not specific to a DVT, but it will be elevated if you have a clot in your system and your body's trying to break it down. Okay, we're going to talk more about D-dimer later when we talk about some other things, but don't forget what a D-dimer is. You guys need to know D-dimer. Okay, anyways, okay, so the other thing, so we always test for D-dimer. So we want to see, are there clots in the system? And then we're also going to do like a CT pulmonary angiography, angiogram is the other thing, or a VQ scan. So CT, remember a CT, when we're looking at blood clots, we need to put contrast in their system to really anytime we need to see blood vessels on a CT, we need to give them contrast because we need them to light up. We need them to brighten up so we can see them on imaging. Okay. Contrast affects the kidneys. Okay. So if your kidneys aren't working okay, you can't get the CT. Okay. The other thing is this is something you guys wouldn't know, but you have to, a CT chest, which is what I'm talking about here, we have to push that contrast at such a high, fast rate. It's kind of like giving adenosine or something. That we need an 18 gauge and an AC, preferably the left AC or right AC. Well, they can take it any AC, but like a little 22 gauge in the hand, CT tech's going to say, "No, ma'am, no, sir, not going to take the patient. You need a bigger blood vessel, angiocath, because the pressure of the amount of contrast that we have to inject and how fast we have to inject it is going to blow any small vein in the hand or wrist or forearm. And if that contrast extravagates into that tissue area, it's going to cause necrosis. So you need, for a CT chest, you need a large IV in the AC or a central line. So if your patient, I say all this because if your patient needs a CT chest, okay, to rule out a pulmonary embolism, and their kidneys aren't working very well, so they can't metabolize and excrete the contrast, and or you can't get an IV in them, then you can't do the CT chest, okay? Then your other option is what we call a VQ scan. VQ scans are not very easily available at most. Not all hospitals can do them. A major hospitals can. We don't typically have somebody that can perform them 24 hours a day, 7 days a week. So we really want to work on that CT chest if we can, but if we have to, we can do a VQ scan, okay? But those aren't very common. We really need the CT chest, just FYI. But you better make sure their kidneys are working good and that you have a good IV. Hope you remember that. Okay, so management for these. Okay, so after we've diagnosed them, we say, yes, you do in fact have a pulmonary embolism. We can treat it several different ways, okay? So you might use anticoagulation therapy with agents like heparin or warfarin to prevent further clots, but that's not going to break down the current clot, okay? So severe case, so we can give thrombolytics if things that actually break down the clot, if it is not contraindicated. A lot of times it is, just letting you know. But we can give thrombolytics, or we can do a surgical embolectomy, which is where they go in and actually dissolve or remove the clot in a surgical procedure. Okay, so we can treat these in very different ways. These are also people that you just want to closely monitor because things can go really bad really quickly on them. These are people that need to be kind of chilling and not, they don't need to be going and running a marathon. They need to, they'll probably be especially if they have a DVT, you don't want them walking around and dislodging it. But if it's already turned into a pulmonary embolism, we need them on bed rest until we have stabilized a clot, because if a piece broke off of a clot before, another piece could break off. Okay. We also want to decrease the oxygen demand on the lungs. And so that's why, guys, it's important to prevent DVTs, because we don't even want to get to this point. But, sometimes it happens out in the community and you're treating it. So anyways, moving on. Okay, so COPD. You guys should already know COPD. It's either chronic bronchitis or emphysema, right? So remember, it's an umbrella term used for those two conditions, both of which lead to an obstruction of airflow and breathing difficulties. So with chronic bronchitis, that is chronic inflammation of the bronchi and excessive mucus production, okay? That narrows the airway. So on this picture down here, it's kind of like that top little circle. That's kind of right there. That's chronic bronchitis, okay? But with the emphysema, it's a destruction of the alveolar walls. So that's kind of, it kind of shows mucus, but like the alveolar walls don't work as well. And so they become larger and fewer. And so that impairs the ability of gas exchange, okay? So patients with COPD typically exhibit chronic cough, increased sputum production, dyspnea, like especially like when they're doing physical activity, going up flight of stairs, those kind of things. They may also get, they may experience wheezing or tightness in the chest with exertion as well. So when we diagnose COPD, that involves pulmonary function tests, okay? That is to assess the degree of airflow and obstruction. Like when we air in and out, is there an obstruction? Is there pressure pushing back on it? We also use chest x-rays to check for lung hyperinflation, okay? Because remember, this is like air trapping. The air will get in and then it's harder for it to get out, okay? And then also we're going to use arterial blood gases to evaluate that gas exchange efficiency. So to manage COPD, we're going to focus on slowing the disease progression and managing those symptoms. So the interventions that we typically do include the smoking cessation, which we all know leads to increasingly significant worsening outcomes in our patients. Also, pharmacological treatments like bronchodilators to relax those airway muscles, which will help kind of open up things and improve the airflow. We can also use corticosteroids to reduce the inflammation. And we also can use supplemental oxygen to maintain an adequate oxygen level. Now, remember, these people typically have a lower normal. They live normally. So we're not going to give them too much, right? We're just going to probably give a little supplemental oxygen just to maintain like 92%. We're not going to be getting 100% on these people, okay? So it's super important for you guys to encourage patients with COPD to adhere to their treatment regimens, engage in pulmonary rehab exercises that helps optimize their lung functions. So acute respiratory failure. What are some of the causes and the management? So what is acute respiratory failure? So it is a condition where the lungs cannot maintain adequate gas exchange. So this could be caused by a whole bunch of different conditions and diseases, okay? So it results in the insufficient oxygen levels, which is hypoxemia, or elevated carbon dioxide levels, which is hypercapnia in the blood. So acute respiratory failure can be categorized into hypoxemic respiratory failure, which is a PaO2 of less than 60, or hypercapnic respiratory failure, which is defined as that PCO2 of more than 45. Okay, I hope you remember that. Common causes include like COPD, severe pneumonia, pulmonary edema, neuromuscular disorders that affect the muscles of the breathing. Okay, so patients with acute respiratory failure often present with acute, meaning sudden, has been going on for forever, dyspnea, use of accessory muscles. Those signs and symptoms are respiratory distress, tachypnea, so they're breathing fast, and sometimes altered mental status because their oxygen amount is not adequate enough to I'm just saying this all wrong. Their oxygen levels aren't high enough or adequate enough to perfuse and get it to all of your brain tissue. And so you can have mental status changes, confusion, and all that kind of stuff. Okay. So severe cases will include cyanosis. Remember, cyanosis is a late sign. Okay. We're going to see these others earlier. So cyanosis, bluing of the skin, graying of the skin, mottling of the skin, those kind of things. So to diagnose this, we're going to use ABGs, arterial blood gases, to assess those oxygen carbon dioxide levels. We're also going to do chest x-rays because that can kind of show us some of those contributing conditions like pneumonia or pulmonary edema. And pulse oximetry because we're going to constantly monitor the oxygen saturation. To manage acute respiratory failure, we're going to focus it on treating what's causing it, okay? Not just symptom. Like COPD is more symptoms, not the cause, but this is more the cause. And yes, we are supporting the symptoms, but we're going after the cause. So if they have pneumonia, we're going to give them antibiotics or diuretics if it's pulmonary edema. remember, they can get a pulmonary edema because they have left-sided heart failure, right? And so this could cause acute respiratory failure because of heart failure. Does that make sense? Because it backs up into the lungs. I'm going to go over more in this class because I have a picture to draw you guys. Anyways, so mechanical ventilation might be necessary to support the breathing in some severe cases, okay? So we can go from anywhere between CPAP, BiPAP, or all the way to endotracheal intubation, mechanical ventilation, depending on how severe the respiratory failure is. So that was acute respiratory failure. Now, acute respiratory distress syndrome, ARDS. Similar, but not, right? Okay, remember the difference. So what this is it's a severe, often life-threatening condition characterized by a widespread inflammation in the lungs. And when the lungs are inflamed, what that does is it leads to alveolar damage and severe hypoxemia that does not respond to conventional oxygen therapy. So no matter how much oxygen we're giving them, it's not responding, okay? The pathophysiology involves the increased capillary permeability in the lungs, which causes the fluid to leak into the alveoli, resulting in impaired gas exchange. So if there's increased fluid that's in the alveoli, it's blocking the air from being able to diffuse through the membranes and tissues, because now there's this thickening and inflammation of the tissue itself. Now there's liquid in there, and now all that oxygen stuff has to travel through all of that before it can be exchanged with the capillaries in the blood. It's so much harder for that exchange to happen. And so that's why the oxygen sats go down. And that's why hypercapnia can go up, because you're retaining that CO2 because you're not able to get it out and not be able to get the oxygen in. So some of the common causes of ARDS include sepsis, significant trauma, aspiration, and also severe pneumonia. ARDS also COVID. COVID led to ARDS a lot too. So patients with ARDS typically experience a rapid onset of severe dyspnea, similar to other things, but rapid, refractory hypoxemia that does not improve with supplemental oxygen. So normally when we give oxygen, things get a little better. This one, not touching it, okay? And diffuse bilateral infiltrates on chest x-ray. So that resemble pulmonary edema, but are not due to heart failure. So the Berlin definition helps clinicians diagnose ARDS, which includes a PaO2 FiO2 ratio of less than 300. I know that doesn't make a lot of sense to you right now, but just go with me. Bilateral opacities in imaging and symptoms not fully explained by cardiac failure, okay? So management of ARDS is mainly supportive, as there's no specific cure, okay? Once it gets this far, it's mostly support, okay? We hope that it doesn't get this far. The goal is the acute respiratory failure, we keep that from turning into ARDS, okay? So mechanical ventilation is essential, often with strategies like low tidal volumes to reduce the ventilator-induced lung injury. So we're not going to be pushing a whole lot of air in and out, just the smallest amount needed. We're going to also prone these patients. They're going to be on their bellies, because that has been shown to improve oxygenation, because it redistributes the fluid in the lungs in different ways. So remember, fluid goes to gravity. And so we're going to prone these patients. You're going to be flipping these patients left and right. Again, I don't know if you remember from COVID times, there were lots of patients being proned. They were laying on their tummies. There's beds that will flip patients. Those are a lot nicer to the staff, because you don't have to do it you don't have to be the ones flipping them anyways. So additional supportive care includes fluid management, nutrition, vigilant monitoring of those complications of ventilator-associated pneumonia or multi-organ failure, because remember, they're not oxygenating well, so all the organs aren't getting enough oxygen, and so this can lead to multi-organ failure. So now let's talk about asthma and status asthmaticus. You already should know about asthma, okay? But what's the difference between that and status asthmaticus? If you have asthma, you should probably already know all of this. So asthma is a chronic inflammatory condition, okay? That's where the airways are, they have episodic reversible airflow obstruction. So like swelling, inflammation, obstruction, shrinkage of the airway, okay? Because of, a lot of times this is because your immune system is hyper responsive, and the inflammation comes on to triggers like allergens, like pollen, pet dander. It could also happen because of physical exertion. Cold air could be a trigger. Infections, stress. There's lots of triggers that can happen. Okay, so patients with asthma will typically present with symptoms like wheezing, because that narrowing of the airway. So it's like the air has to go through a smaller opening, so it's going to cause a higher pitch, like a whistle. Just like when you like make your mouth into like a small little circle to actually whistle, you're closing the airway to make it small. And so when the air passes through, like your lips, it makes a whistling sound. Well, it's the same thing in the lungs. Wheezing, okay? Dyspnea, so difficulty breathing, chest tightness, coughing. Bronchospasms are common. That's the right word. And they often typically get worse at night or like early in the morning, or they get worse because of an increased activity. Okay. So, but sometimes asthma turns into status asthmaticus. So what that is it's when asthma escalates to severe life-threatening condition. Okay. It involves prolonged asthma attack per se, that does not respond to the usual rescue medications like albuterol. Okay. And albuterol, remember, is a short-acting beta agonist. Hope you remember that. You should remember that. Management of status asthmaticus often includes super aggressive treatment with repeated doses of those short-acting bronchodilators, corticosteroids that will help reduce that inflammation, supplemental oxygen to maintain adequate oxygenation. It also, a lot of times we will give mag sulfate, magnesium sulfate. Remember, that is a smooth muscle relaxer. It can be administered to help relax those airway muscles in refractory cases. So remember, what are some of the side effects of mag sulfate? So if somebody has status asthmaticus and you're giving them mag, what are some of you've given mag before for other things. We've given mag for torsades, right? We've given mag maybe to slow down contractions in labor. Mag is mag, no matter what you're giving it for, you have the same side effects. So you should already know the side effects to this. Hint, low blood pressure. It can, and I will tell you that we typically give 2 grams, which is a lot, very fast, like over like 10, 20 minutes. And that can drop blood pressure really quickly. So we want to be monitoring their blood pressure before, during, after, like every 5 minutes while we're giving this mag infusion. It's going to be on a pump. We're not going to like let it hang to gravity by any means. We're going to be monitoring them, making sure that they're not hypotensive. We're probably going to hang a bag of fluids just to give them fluids, and just because they're probably going to have lower blood pressure than normal. So let's fill the tubes up with some extra fluid, right, to kind of offset the lowering of the blood pressure that the mag is going to cause. That's very common, FYI, to give that. So nursing interventions are super important in managing the asthma. Don't forget that. And you also prevent the exacerbations. So we want to prevent them from getting worse. So education on asthma patients. Okay. So they need to know how to use the proper inhaler technique. I see it all the time. And you should already know all this. Patients will like inhale and they spray it on their tongue and they don't actually inhale. Spacers are amazing. There's spacer picture right here. The little girl on the left. Guys, adults can use spacers. I think that everybody that has an asthma inhaler should use a spacer, because you pump it into that chamber and then you can just breathe it in and it's sealed around your face. It's amazing. It's great. Use it. Okay, anyways, but that, like albuterol and stuff, those are rescue inhalers. They don't do very much. Those corticosteroids, those are the things like Advair and stuff. Those are actually helping repair the lungs and prevent the actual triggering effects from the get-go. Kind of the way I like to explain it to patients, and you can maybe remember this, like having an asthma attack is like being in a boat in the middle of a lake and there's a hole in the boat and there's water coming in. Okay. What that inhaler is doing is it's like you having a bucket so that you can like scoop the water out and like shove it overboard, but the water's going to keep coming in. Like, it's great. It kind of helps you from sinking right now, but like, it's not going to do anything in long term. Those corticosteroids, that's like patching up the hole in the boat, and it's going to stop the flow of water from coming in. It's going to stop your airways from closing. Okay. So like, that's preventing it from getting worse. Okay. Super important. So often I see people with asthma, they skip on the corticosteroids because they're more expensive, and they just treat, and I use that term loosely, treat their asthma with just a rescue inhaler. No. Rescue inhaler should be not used very often. If you are hearing your patient is using a rescue inhaler like 3 times a week, we got some problems, probably some educational deficits there that we need to talk to them about and figure out what's going on. So that's asthma and status asthmaticus. And do we sometimes have to intubate these patients and put them in the ICU? Yes, definitely. It happens, especially if somebody is poor controlled. They haven't been using their they've been overusing their albuterol and not using the corticosteroids for the prevention, and they haven't been avoiding the triggerings. They haven't been taking allergy meds, those kind of things. And it just sometimes they just have an overreaction to it. And we have to support them with a ventilator for a few days until like we can get their immune system under control so it stops trying to close down the airway, because that's not good. Okay, so now let's talk about some adjuncts to airways that you might see in critical care. There's oropharyngeal, nasopharyngeal. That's like, we went over these in the ACLS. Those are like the nasal trumpet, the oral airways. ET tubes, that's the endotracheal tube. That's what you think of when we think of intubating a patient, putting them on a breathing machine. That's the tube that goes into their lungs. Tracheostomy is the hole that's for more long-term ventilatory assistance, not like short-term, like we're talking, they're going to be on it for months, years, maybe their whole life. We're going to go through their trachea. Okay. Like from the outside in. So we use the different types depending on what's going on. Remember, there's correct sizing for each one of these. Like, it's not one size fits all. You have to go based off of which type you're using and the condition. You should have already learned most of this. I'm not going to ask you questions on specifics on this, but just if you've learned anything about sizing in the past for anything like that, or care for like tracheostomy, wound care, like you want to keep it clean and all that kind of stuff, dressing changes and that kind of stuff, just review that from med-surg. You just want to make sure you know all that kind of stuff. We're going to get a little bit more into mechanical ventilation now. Now, I'm going to preface this with, I am not strong in this topic because I'm an ER nurse and I have respiratory therapy hold my hand every time somebody's on a vent. I'm great about intubating them. I'm great about bagging them manually, but when you want to hook me up to a ventilator and now I have to manage you, or hook the patient up to a ventilator, now I have to manage you for the whole shift, I am looking up, looking right, looking left, like, where's RT? If it starts beeping at me, it's yelling at me, and I might know how to do a few things, but I'm by no means an expert because I'm an ER nurse. We're not an expert at anything. We're just jack of all trades, master of none. I'm calling RT. They're like, come help me, come help me. Okay, anyways, so, but I can go over the basics, and the basics is all you guys need to know for nursing school. Okay, so mechanical ventilation. What is this? This is a life support technique that we use when a patient cannot maintain that adequate gas exchange on their own due to severe respiratory failure, okay? The indications, some of the reasons why we would do this include respiratory failure, like acute respiratory failure or ARDS, okay, acute respiratory distress syndrome. Severe exacerbations of COPD is another reason. Like I said, we could also do it for asthma. So we're talking about using the vent because of a respiratory condition. Do we use a vent on perfectly healthy people? All the time when we put them under, per se, for surgical procedures, right? So some of these concepts are applicable to other things, but we're using the ventilator. What we're talking about today is we're using the ventilator specifically because the patient is having an issue with the actual gas exchange issues, okay? So the primary goal of mechanical ventilation is to ensure that sufficient oxygenation and ventilation is occurring. Oxygenation means the ability for that gas exchange. Ventilation is moving the air in and out, okay? So, and then also the other goal is, like, we want to reduce the patient's own work of breathing, okay? So we're going to kind of do it for them, right? So mechanical ventilation can be delivered invasively through an ET tube, endotracheal tube, or tracheostomy, or non-invasively using a mask like BiPAP and CPAP. Those are forms of ventilatory assistance because they are actually helping ventilate or actually physically move air in and out. They are a form of ventilatory assistance, okay? So the choice on what we use depends on the patient's condition, the severity, and also provider preference, okay? Mechanical ventilation, though, is not without risks, okay? So there are some potential complications. So one of them is ventilator-associated pneumonia. This is a big one. We don't, it's like getting a CAUTI. We want to prevent these in the hospital setting, well, any setting, okay? And patients are more at risk when they have prolonged intubation, or barotrauma, which is trauma to the lungs from excessive airway pressures. So like we put the pressures too high, we're too high of tidal volume and all that kind of stuff in the settings of these. Also, hemodynamic instability caused by the changes in the intrathoracic pressure that affects the venous return and cardiac output. So this is also like the pneumothoraxes and stuff, okay? So weaning the patient is a process of gradually reducing the ventilatory support. So The goal is to use this to help support them until they can naturally heal, until we have time to stabilize the other contributing factors that are leading to the oxygenation issue, right? And so once we've stabilized that or things start improving, we want to start weaning the patient. And so when we do that, we will gradually reduce the patient's need in assistance with the ventilatory support. And while we're gradually hoping that the patient picks up on the slack and starts breathing on their own occasionally. Okay, so this is initiated once the patient, like I said, shows signs of recovery and improved in respiratory function. So effective weaning protocols are different per facility. So wherever you go to work, follow whatever protocols and policies are there. But you guys need to be closely monitoring the patients to ensure that that patient can maintain adequate breathing independently as you're weaning them. So some modes of ventilation. This is a page. You need to know the difference between these, okay? So there's several modes of mechanical ventilation. Each one is tailored to a different patient need and a clinical scenario, okay? So go with me on this journey. Assist control, AC for short, is often used in patients who need full ventilatory support. Okay, in this mode, the setting on the ventilator, every single breath that the patient has, whether it's initiated by the patient or the ventilator, is fully supported with a set tidal volume, which ensures that the consistent ventilation may be led to breath stacking in some patients. So what that means is, like, sometimes a patient, when we set these modes, sometimes it's doing the full ventilation where like it's doing every single breathing for you. So we've probably paralyzed you and all these kind of things. You're not working to breathe. The patient's not working to breathe at all on their own. We're doing all the moving and exchanging. Okay. But sometimes the patient will take a few breaths per minute. Okay. So in that case, this is one of the settings that we can do where sometimes the patient is taking a breath and sometimes we're pushing and pulling the air in and out on, to assist them. Okay. But each one, no matter who's initiating the breath, the machine or the patient, we're fully supporting and making sure the tidal volume, so the amount of air that's going in and out, is consistent in the same amount. Okay. That's assist control. Now, SIMV, synchronized intermittent mandatory ventilation. What this one does is it combines mandatory breaths with the patient's spontaneous breathing efforts. The ventilator synchronizes with the patient's efforts, allowing them to breathe independently between the mandatory breaths. This mode is often used during weaning as it encourages the patient to take more control over the breathing. So this one isn't necessarily making sure when the patient breathes on their own, it's letting them do their own work on that. When it the tidal volume and everything is up to the patient when they're taking their own breath. But this is kind of like that intermittent thing. Okay, so this one isn't as much control, but it is allowing both the ventilator to have some breaths and the patient to have some breaths. But when the patient breathes on their own, they're on their own, if that makes sense. So pressure support ventilation provides, that's PSV, provides positive pressure to assist with each spontaneous breath, making breathing easier and less taxing. It's commonly used in the weaning process as well. So pressure control ventilation, PCV, limits the pressure delivered to the lungs, making it safer in cases of poor lung compliance, though tidal volumes may vary, requiring close monitoring. So again, this is just helping those spontaneous breaths with some extra pressure just to kind of keep so maybe you're kind of a weak breather. The patient isn't doing really big, good deep breaths. So we need to add a little extra. So it synchronizes to the patient's breath and it helps add some air if needed so that the lungs fully inflate and deflate in the inspiration and expiration. Okay, that's PSV. PCV, I'm sorry, did I just say that wrong? So PSV is pressure support ventilation. Pressure control ventilation controls the pressure, but the tidal volume varies. Okay, so PSV is with each spontaneous breath, and it's commonly used in weaning. PCV is the one where it limits the pressure delivered to the lungs, so it's not allowing a whole lot of air to go into the lungs, which is safer so that the lungs don't fully inflate. Okay, PSV is positive pressure to assist with the spontaneous breath. So it's adding air, but PCV is it's controlling that amount. I hope that makes sense. Okay, moving on. Inverse ratio ventilation, IRV. Okay, this one's less commonly used, okay, but it is primarily used in ARDS, in the acute respiratory distress disorder. syndrome, to improve oxygenation. And so what it does is it prolongs the inspiratory phase. So it makes the inspiratory a little bit longer, which that can help recruit more alveoli to actually open up and do gas exchange. But this does require heavy sedation because it's super discomforting to the patient. Okay. But so it helps like keep the inspiration longer and slower. So it keeps everything open, and then, exhalation, and then inhalation is longer and slower so that gas exchange can happen, and then exhalation. But it can cause a lot of anxiety in patients. That's why it's not that common, but it's used a lot in ARDS. So CPAP. What is CPAP? Okay, continuous positive airway pressure, CPAP. That provides a constant pressure throughout the respiratory cycle to keep the airways open. Remember, every time you exhale, like things like your alveoli kind of like collapse and kind of go down. But they never fully go down. But every time it's like blowing up a balloon. When you first blow air into a balloon, it takes a lot more pressure and air to like get it started, right? So if you were to like let air out, as long as you don't let the air completely deflate all the way down, it's easier to add more air to it and let a little out, add more air to it, add a little out. But if it goes down and it shrinks down, it's so much harder to get it fully opened again, right? So what CPAP does is it keeps pressure in it. It doesn't allow all the air to escape, and it's constantly keeping some pressure in the system that keeps that alveoli open. That helps with gas exchange, okay? This is super beneficial for patients with obstructive sleep apnea, or those people that just need minimal support just to keep that alveoli open. Okay, some advantages and disadvantages of ventilator modes. We're kind of going back to them. So that assist control, okay? Assist control mode is kind of a review, but we're going to kind of go into it a little bit more. That provides full ventilatory support with each breath, fully supporting whether triggered by the patient or the ventilator. So while this mode ensures that consistent ventilation, it also carries the risk of breath stacking and hyperventilation, especially if the patient starts breathing spontaneously at a higher rate. So it's like, and like you're not fully able to get all that air out. That's like the breath stacking. And so you can see how that might cause issues. Synchronized intermittent SIMV ventilation. So that, remember, it allows for spontaneous breathing between set ventilatory breaths, which reduces the patient ventilator dysynchrony, and it promotes more of that natural breathing pattern. It's often used in the weaning process, but some of the disadvantages, okay, it can increase the work of breathing if the patient's spontaneous breaths are inadequate, okay? Now, PSV, pressure support ventilation. Remember, that augments and helps spontaneous breaths with a preset level of pressure, reducing the work of breathing and making it easier for the patients to breathe. But on the flip side, PSV does not control CO2 levels as effectively, which can be problematic in certain conditions, okay? The PCV, which is pressure-controlled ventilation, limits airway pressures, making it a protective strategy for patients with the fragile lungs, okay? Especially those with ARDS. However, it has variability in the tidal volume, and the tidal volume is the full amount of air that's going in and out, and that can complicate gas exchange. And it does require that close monitoring. So inverse ratio ventilation, or IRV, that's that one that prolongs that inspiratory phase, which improves the oxygenation of patients with ARDS, but it can also be uncomfortable, and it typically requires deep sedation or paralysis of your patient. Okay, so that's kind of the bad thing on that one. So the non-invasive modes like CPAP and BiPAP, both of those offer ventilation support without the need for intubation, which makes them less invasive. So that's a positive. But on the flip side, they're not suitable for all patients, particularly those that cannot protect their airway. So we need to keep the airway open, or they have like a floppy tongue in the back, or those that are critically hypoxemic. So people with ARDS, like it just doesn't provide enough support. So we have to go more invasive. So patients on mechanical ventilation, what do you guys need to know as a nurse? So patients, the nursing care for these patients requires a lot of close monitoring to ensure that that patient is safe and comfortable, okay? You're going to be conducting regular assessments of respiratory status, including monitoring the breath sounds, the respiratory rate, and the effort to detect any signs of deterioration, okay? It's essential and super important to frequently check the ventilator settings to ensure that they match the prescribed parameters. What are the doctor's orders? Because sometimes people come in there and they just tweak things, and it's not due to a specific reason. Now, can you adjust the ventilator settings? Yes. You do it based off the patient presentation. And this is where I become weak, is understanding what exactly needs to be adjusted and how much. This is where I will defer to an actual ICU nurse that takes care of ventilated patients all day, every day, and or respiratory therapy. Like, I understand that something needs to happen and I understand what's going wrong, but I don't understand necessarily what to change. Okay. I don't expect you guys to know that either, but if you go into the ICU, you will know this. So, remember, like, when the alarms are going off, there are several reasons for this. Okay. It's either like something got disconnected. There's like an obstruction in the tube. Maybe the patient's biting the tube. That could be an obstruction. Or the patient's condition has changed, and so now it's not providing enough support. So now the oxygen sats are going down, or maybe it's providing too much support and we don't need it as much because the patient started breathing a little bit more on their own. So there's reasons why alarms can go off, and you need to go and check those kind of things. Okay. Proper placement of the ET tube is, of course, important because that's one of the biggest things. Okay. So if the alarms are going off, you want to check first for the displacement or disconnection. Okay. So there's a mnemonic people use. It's DOPE. If you want to remember that. Okay. So what you're going to do is you can confirm its position of the ET tube, regularly using the securement device and monitoring the markings. So wherever it was, whatever they like at the teeth or at the lips. I will tell you that a lot of nurses prefer teeth because lips can swell or get smaller depending on like fluid status or sepsis. There's all different starts. So like if you mark, like if you're documenting where the ET tube is at the lip, that might change, but the tube might not have moved versus the teeth. The teeth are pretty consistent. And so wherever it is at the teeth, if you mark like it's 22 centimeters at the teeth or whatever, then that should be pretty consistent no matter what's going on with the patient. And you confirm that it's whatever it was from the last shift, it is on the same shift. Okay. So, also, to prevent ventilator-associated pneumonia, a common complication of prolonged intubation, we do oral care. People that are intubated need to have constant oral care. Don't think that it's not a big deal. It's a big deal. So you'll use like chlorhexidine mouthwashes. You'll suction the patient as needed to keep the secretions from like causing issues. We're also going to elevate the head of the bed between 30 to 45 degrees because that helps reduce the risk of aspiration on patients that are mechanically ventilated, as long as it's not contraindicated. So these patients also might require sedation, most likely, and analgesia to ensure the comfort and reduce anxiety or agitation. I'm telling you, if somebody's breathing for you and you're kind of awake, it can be very anxiety ridden. Like it's just not a natural feeling, and patients can become super restless. So also don't forget, you need to collaborate with your RTs, your respiratory therapists. This is super important. Okay. Especially when you're weaning the patient up from the ventilator. They are the experts. They know a lot and they can help you. You want to gradually reduce the ventilator support, and that will allow for the patient to have like a smoother transition back to spontaneous breathing. But you're going to have to continuously assess them and see if the patient's able to tolerate it. Because a lot of times when you wean, you may have to go back. It's kind of a give and a take. It's not always just in one direction. So some other complications that we're going to talk about. So ventilator-associated pneumonia, we've already kind of briefly talked about this, but remember, this is a big one. Significant concern, okay, due to the presence of an artificial airway. Okay, and also remember, we're probably sedating these patients. Their ability to clear secretions and cough things up, it's decreased. So we need to be vigilant on like that oral care and suctioning, elevating the head of the bed to reduce the aspiration, and those kind of things like we already went over. So barotrauma are forms of, it's a form of lung injury that occurs when that I've already kind of talked about this, but when like high pressures or high volumes of air are used during ventilation, it can cause over distension of the alveoli and it can cause damage to them. So you need to be protective with your ventilation strategies, and like using the lowest tidal volume you need to get the goal accomplished of ventilating your patient. Also, you need to be looking at hemodynamic instability because that is another complication resulting from that positive intrathoracic pressure that can impair the venous return of the heart, reduces the cardiac output, and reduces the blood pressure. So we want to make sure that we're monitoring all the vital signs all of the hemodynamic parameters, making sure they're within the normal ranges. And if they start going out, we need to be asking ourselves why, what's going on. And we need to be intervening if we can, or notifying the physician so that they can intervene if they need to be taken back to the OR or whatever the case may be. Okay. So remember, prolonged immobility associated with mechanical and ventilation is also going to increase the risk of the venous thromboembolisms. Okay. So DVTs can pop up. Okay. So our job as nurses is using pharmacologic and also other extraneous things to prevent the thromboembolisms. Okay. So SCDs, physical therapy, moving, legs, stretching legs out. As a patient, I always begged that they didn't put the SCDs on me. They're so uncomfortable. I was like, I promise I'll do I'll do running motions in bed. I will do leg stretches. I will do whatever you want every 10, 15, 30 minutes while I'm awake. If you promise you won't put those on me. I know I'm a bad patient, and you will have patients just like me that will beg for you not to put them on. But, you explain and educate them why they need them, because the last thing we need is for you to get a stroke or pulmonary embolism because you had a blood clot that dislodged because you were laying in bed, blah, blah, blah. But if they're sedated, they're not going to be complaining. So just remember all that stuff. And remember sedation management and preventing delirium, and also supporting the families. So trachs. Little review of trachs, kind of going over it. So a tracheostomy, remember, it involves creating a surgical opening in the trachea to provide a secure and stable airway. This is often when patients are going to require long-term mechanical ventilation, or those with a significant airway obstruction, due to neurological impairment or stuff like that. So sometimes you have people will also be on this that are paraplegic. If depending on how high the spinal injury is, they may have to end up with a trach long term forever. So things that you can do to improve patient comfort that have prolonged endotracheal intubation or tracheostomy, you need to make sure that they're doing cleaning care, that you're cleaning it, you're suctioning it, you're doing wound dressing changes if it was newly put in. Suctioning is a big one that is sterile. So you also want to be looking at those complications. Again, if you just put it in, infection, tracheal stenosis is a narrowing of the trachea due to scar tissue or inflammation swelling around where the trach was inserted. It can also get dislodged. You can also have bleeding occurring, all those kind of things. So you want to be monitoring those and intervening as needed. Of course, there's patient family education, just caring for the site. If it does dislodge, what you need to do, if you see on this picture, there's a little cuff on the inside. So you can inflate or deflate the cuff. They need to be checking to make sure it's fully inflated, and it's typically 10 cc's of air. Depending on, let me just preface, children versus adults, there's different sizes. So just make sure you follow whatever it is on that actual trach. And it often on the little cuff where you you attach the syringe to do the air, it'll tell you how many cc's are on it. So don't keep that as a standard thing, because they're different sizes depending on what it is. And then also a lot of times that they have to cover it to speak, if they're able to speak. And so there's also valves that can be that depending on the trach, if it has it or not, that sometimes people just cover it up with their hand and those kind of things. So now ABGs, you should already know this. This should be a review, but just a little review. Okay. This is a very important thing that we assess, in respiratory status. We do ABGs. We can also use venous blood gas. They're not as specific, but a VBG versus an ABG, it's just did the blood come from a vein or did it come from an artery? Artery is more specific. It's better for targeted interventions, but sometimes all we have access to is a VBG, especially in the ER. And so VBG is great until we can get an ABG. So this test is going to provide those key parameters, including the pH, which is the acid-base status of the patient, PaCO2, that's the effectiveness of ventilation, so the actual movement of air. PaO2 is the level of oxygen in blood, so that's that gas exchange. And then the HCO3, that's the bicarbonate, that shows metabolic components. SaO2, that's the saturation of oxygen in the hemoglobin, just so you remember. Understanding these values is going to help you determine whether the patient is experiencing respiratory or metabolic acidosis or alkalosis. Remember, the two organs in your body that work on keeping like homeostasis, that are like buffering systems, they work on the pH, the acidity, like making sure everything stays copacetic and balanced. The two things that work in tandem together are your lungs and your kidneys. Okay. So metabolic is more your kidneys, respiratory is more, well, it's all of your body. But when there's issues with your kidneys, you're pretty much probably going to be in metabolic acidosis or alkalosis. And when there's issues with your lungs, you're probably going to be in respiratory metabolic acidosis or alkalosis, but not always. It's not always the case. So remember, the normal pH range for somebody is 7.35 to 7.45. Values below that, so less than 7.35 is acidosis. Values above it are alkalosis. Don't forget that. PCO2 range of 35 to 45. Primarily, that's a marker of respiratory function. Okay. High levels of PCO2 indicate hypoventilation, respiratory acidosis, and low levels of that suggest hyperventilation, which is respiratory alkalosis. HCO3 levels, normal between 22 and 26. That reflects metabolic component. Okay, so deviations in these ranges help identify the metabolic acidosis or alkalosis. Now, remember, you can be those metabolic acidosis, alkalosis, or respiratory acidosis or alkalosis, but you can also be compensated. So compensation refers to how the body attempts to correct the acid-base imbalances, okay? Compensations can be partial when the pH is still abnormal, but it's moving towards normal. It could be fully compensated when the pH is back within the normal ranges, or completely uncompensated when there's no corrective measures at all in any of the lab values. So nursing considerations for ABGs. What do you need to include? So you need to assess for those underlying conditions that are causing the imbalances. You need to monitor for trends over time. You need to collaborate with all the healthcare team to adjust the treatment plans accordingly. So this might be ventilator settings. If they are hypoventilating, that means low ventilating is the movement of air in and out. So they're low moving the air in and out. So they have respiratory acidosis. We need to increase their respiratory rate. So we may need to change the vent settings. I'm telling you, RT is going to love you a lot of times. I mean, you're going to love RT because they will help you with these so much in the real world. And in fact, RT, a lot of times they're trained to do arterial sticks, and obtain arterial blood to run the test for ABGs. So a lot of times RT is the one that does it, but definitely nurses are cross-trained for it. So you guys need to be able to get a scenario, get lab values, and be able to tell me if it's compensated, not compensated, respiratory, metabolic, acidosis, alkalosis, whatever. You need to know these and be able to tell me what is what and interpret the findings. Okay, so some diagnostic studies. Again, you should know a lot of these. So what's a chest x-ray? It's just a picture of your chest, and it shows like the inflation. You can do a 1 view or 2 view. 1 view is just from the front to the back, or back to the front, like it's just looking at you from the front. 2 view includes that, but also the laterals from the sides. 2 views are always better than 1 views. To see more of the lung, a lot of times you miss pneumonia on just a 1 view. You need a 2 view if you can get it. So chest x-ray, very, very commonly used, right? Like you can see things like pneumothorax, pneumonia, pleural effusions. That VQ scan we already talked about, that's a nuclear medicine test that evaluates both the ventilation, the airflow, and perfusion, the blood flow in the lungs. So we use the VQ scan to look for that pulmonary embolism, because if there's a blood clot in the lungs, the blood flow will be impaired, right? But we can also see it with a chest CT. Okay. So pulmonary angiography is considered that gold standard for diagnosing the pulmonary embolism. It's the CT. It involves the injection of the contrast into the pulmonary arteries to visualize any blockages. Bronchoscopy is another vital diagnostic tool that allows the direct visualization of the airways. So we're putting a scope down your throat to look into your lungs and your airways. We're visually looking, right? They can see like lesions, maybe foreign bodies, those kind of things. What is a thoracentesis? Thoracentesis is a procedure where there's a needle that's inserted to the pleural space to drain fluid. So we can actually pull the fluid out that way. It's not the most You're going to do that in the OR, hopefully not emergently at bedside. Can you do it at bedside? Yes. In the ICU and the ER you can, but hopefully you go to a ER for that. Pulmonary function tests, those are a set of tests that measure how well the lungs are working by assessing lung volumes. They assess the capacities, like how much you can actually contain the air, the volume of the air, and the flow rates, okay? PFTs are particularly useful in diagnosing and monitoring chronic respiratory conditions like COPD, asthma, and they help us tailor and make specific targeted treatments and strategies for patients with those conditions. So now let's talk about malignant hyperthermia before we're done. What is it? Okay, it's very rare, very, very, very rare, but it can happen, and it's potentially fatal. Okay, it's triggered by anesthetic agents, mostly gases. Okay, so volatile inhaled anesthetics, and the one IV med that is more susceptible for causing it is succinylcholine. So sucks for short. So which is a muscle relaxant. We use that when we're intubating people a whole lot. And the gases typically used by anesthesia when we're, again, sedating and putting people under to put them on a ventilator. Okay, so malignant hyperthermia results when it's like a genetic mutation that causes abnormal calcium release from, I have to write this down, sarcoplasmic reticulum in the skeletal muscle. Just know it causes calcium release in the muscle, which causes hypermetabolic state in the whole body, which is characterized by rapid and uncontrolled muscle contractions. Okay. Malignant hyperthermia. It's not what it sounds like, but it is. Okay. So symptoms include a rapid, very fast rise in body temperature. That's the hyperthermia part. Muscle rigidity, often beginning in the jaw. They'll have like a clenched jaw. So if they're intubated, they might like bite down and clamp on the ET tube and they will not release it. Okay. You'll also see tachycardia, an increase in carbon dioxide production, and metabolic acidosis. The condition can progress super quick, okay? So you need to be watching your patient. Oftentimes when we sedate patients, when we're doing like a conscious sedation, moderate sedation, or right after we intubate patients, we're going to take their temperature. Especially if you start to see flushing and the heart rate rise on your patient, go take their temperature. If it's not like hopped up, we need to be like looking into other things. Like we need to be notifying people, okay? That's why you also get a baseline temperature before you take them and give them any of these anesthetics and before they go into surgery. We're going to get a baseline temperature because we need to know if it's rapidly rised, right? Right, risen, not rised. Sorry. Okay, so this condition can progress super quick and it can lead to severe complications like rhabdomyolysis. That's the breakdown of muscles across your body, which then will destroy your kidneys. That's not good. Hyperkalemia, a lot of protein, that will stop your heart. Also not good. And cardiac arrest. Triple not good. Okay. So if you don't treat this properly, it can lead to those things and basically it can lead to death, right? So what do you do if you suspect your patient is developing malignant hyperthermia? Okay. First thing you're going to do is discontinuing that trigger anesthetic agent. Okay. So we're going to stop the gas if it is. If you IV push succinylcholine, you can't really stop it. So what's done is done. But there is a reversal agent, dantrolene. You need to remember that. That is a reversal agent, dantrolene. Don't forget that. NCLEX, this is one of those. A lot of people I've talked to over the years have had a question about malignant hyperthermia, and dantrolene is the answer. I can tell you that when I took my CEN, dantrolene was on there. I guarantee you if you take a CCRN exam, dantrolene is probably going to be on there for malignant hyperthermia. It's just a question we love to ask, dantrolene. Remember dantrolene. Malignant hyperthermia, dantrolene. Where do we keep dantrolene? Is it in the Pyxis? Probably not, unless you're in the OR Pyxis. It's probably on the OR crash carts, okay? If you are somewhere in the hospital and you need dantrolene, you can call the pharmacy, but the better option is to call the OR, no lie. That's probably where it's stored in the whole, they probably don't store it in the pharmacy because you need to get it in the system really quick, and so they're going to store it close to where patients are most likely going to need it, the OR, okay? But can they develop it in the ER or the ICU? Yes. Do we sedate people there? Yes. Do we push succinylcholine? Yes. So it can happen, okay? So just remember that. And you're just going to be, like the other things you're going to do is obviously monitor their vital signs. You're going to be probably doing cooling measures like ice packs, cold IV fluids, because we want to bring the temperature down, but not too fast, right? And you're just going to be doing supportive care, okay? You're going to be watching EKG changes. If they have hyperkalemia, you're going to see what on the EKG? a peaked T wave, okay? So we might have to do things to bring that potassium down, okay? We also, if they go into rhabdo, we're going to see like super dark urine. That's a sign of rhabdo before it destroys your kidney. So we're going to be flooding that patient with lots of fluid. So we dilute it and we hopefully get all the breakdown of muscles and stuff out of the system so that we don't cause all sorts of other issues. But yeah, that's malignant hyperthermia in a nutshell. So a little review. We talked about all those things. You can pause and read the screen, but we're at the end of the module. Remember to do your readings and go over the learning objectives before the lecture and definitely before the test. And I will see you guys in class.